Good evening, everybody. On behalf of the Dean, Eileen Sullivan Marks, and administration, I welcome each of you, and I'm so glad that you're here tonight. In spite of the weather, we know that the weather probably kept a few people away. It's been quite a day. But we're glad that you're here, and especially for the start, really, of our Estelle Osborne celebration events for the entire month. This is sort of our kickoff, if you will. And so we invite you to enjoy several of the stations that are around here and enjoy yourself for the rest of this evening. This is really the beginning of a month-long celebration of diversity, equity, and inclusion, which Estelle Osborne brought to NYU many, many years ago. And ever since then, we've been honoring her for that privilege. So we're glad you're here, and we're glad that we are able to have such a distinguished speaker here tonight to help us. And so let me introduce you to Nathan Levitt, please. Nathan Levitt is one of our own. He is an undergraduate student. Well, was an undergraduate. I guess forever a student, right? Was one of our own, and I sneaked a peek at his transcript today. And I will not reveal anything except he was an excellent student, and that he came to us with a Bachelor of Art degree from Emory University in Atlanta, where he majored into the equivalent of gender studies. And so then he began his career with us, and toward the end of his career with us, he examined the LGBT curricula and said we had some things we could add to it. And so he actually did an independent study during his final fourth sequence within the School of Nursing program. And I saw, Nathan, that you took 21 credit hours in your fourth semester. That's just incredible, 21 hours, and did quite well. Well, anyway, back to my script. Nathan is a family nurse practitioner, board certified, and is the coordinator of the Transgender surgery program at NYU Langone. And before I read further, I'm so glad that has happened. Not only is it our flagship down the street here, flagship academic medical center, but I can remember working in a site where you used to work, as a matter of fact, where people would want to begin that process, and we had to refer them out of the country. I can remember writing letters and talking to physicians, and I knew not where we were sending some of our patients. So I'm so glad that we finally have come up this far. Nathan previously directed the Transgender Care at Community Healthcare Network, creating, implementing, and providing training on transgender health policies and protocols for a total of 12 primary care clinics, to include their social workers, patient navigators, mental health departments, nursing and medical staff, and he also provided primary care across all of those patient populations at those sites. He was there and New York's first Family Nurse Practitioner Fellowship program at CHN. Nathan works as a transgender health consultant to the New York Department of Health and has served on their transgender and gender nonconforming advisory group to ending the epidemic blueprint that guides HIV prevention and treatment and health needs of the transgender community throughout New York State. Nathan worked for 8 years at Callan Lord Community Health Center as the Community Outreach and Education Registered Nurse and the Community Education Coordinator, where he provided care for LGBT patients, built transgender health programs, and created and facilitated the curriculum on transgender health. His registered nurse hospital experience includes 5 years at Maimonides Medical Center on the oncology unit. And he has worked as a community organizer, program coordinator, researcher, consultant, trainer, and health educator with international and national organizations for over 15 years, which means that you started around the age of 3, probably. Nathan trains community health centers, health professional schools, hospitals, and community-based organizations, and has published widely on transgender health. Nathan, it is indeed my pleasure, our pleasure at Myers Nursing to welcome you, our own Nathan Levitt.
Hi, everyone. It's so nice to see you all. We don't have any time because my bio took the whole time. So I'm sorry about that. I didn't realize how long it was. But it's wonderful to be back here and to see all of you, some familiar faces, and to talk a little bit about the work that I do. I feel like a lot of my grounding came out of NYU Nursing School and really being able to look at the curriculum and what could be improved and what was going well with LGBT health, and it's so wonderful to see how much progress we've made. So I'm going to talk very fast, so just show me a face like you need to slow down if I've talked too much, okay? Because I have a lot to cover, but I also have my cards up here, so you're welcome to email me or call me anytime for more information, okay? So we're gonna start out with just a quick question. How many of you have had any training or experience in transgender health? Raise your hands. Okay, wonderful. And is transgender health included in your curriculum in nursing practice? Sorry. So raise your hand if it's included. Sort of, maybe. And then this is more of a question to think about for yourself. If you had transgender patients right now, how equipped would you feel to address their health needs? So for many folks that are students right now, you might not feel equipped to address any needs of any patients, but definitely for transgender health, that can be really difficult, right? So there's a lot of different needs in the transgender population. So I wanted to focus a little bit, this is sort of a study that happened a little while ago about silence in nursing school, right? And this is why it's so wonderful that NYU Nursing School is focusing on LGBT health, because for so long there were only 0.16% of articles that focus on LGBT health. And this doesn't really tell you about transgender. I would imagine much less for transgender, right? So when you're out there learning about transgender health and LGBT health, you don't have a lot to go on, right? You don't have a lot of research that's out there. And what can that do? So if you're thinking about that there's no information on LGBT populations, so the silence in nursing school can basically render this population invisible, right? So what happens is a lot of wonderful nurses, RNs, and nurse practitioners are coming out of school with maybe great intentions to take care of this population, but no real information about how to do so. And how to take care of this population, it goes beyond how to address the population, which is incredibly important, what names to use, what pronouns to use, but also there's a lot of clinical information too. So I'm going to focus on just a fraction of the amount of clinical information and sensitivity issues there are. So why is this important? So hopefully all of you are here because you think this is really important, also for the free drinks and food, I know, for sure. But this is important because transgender people are in need of so many different services. So we know as nurses, any of you who have been practicing as nurses or just in school, that we cover patients' holistic needs, right? We think about not only what are their health issues, but also do they have housing? Are they connected to community? Who's taking care of them? And transgender populations have so many different social services needs, and they face so many barriers. Many trans patients will just avoid care in general. So if you just show of hands, how many of you have had transgender patients before? Okay, so a lot of you. So maybe you've noticed that a lot of your transgender patients have a few different chronic health issues that they've maybe never come in for care before. And we often think for our patients, why did you not come in? You had this pain, or you had these issues, or trouble urinating, whatever it might be. Why did you not come in? And for a lot of our trans populations, it's because if they ever need to talk about their bodies, especially parts of their bodies that are very gendered, they're not going to come in for that care, right? And so we end up seeing a lot of transgender patients, sadly, in the emergency room because those health issues get so difficult. And there are very few health providers and hospitals in the country that are sensitive for this population. So hopefully all of you are going to go out there and become amazing nurses, if you aren't already, and take care of this population, because so much is word of mouth, right? In the trans community, we talk to each other, we say, that was a great RN, that person was a great NP, and then we know that's the place we're going to go to. I know you all have time for lots of extra reading, right? You're not busy or anything. So there's some great resources, Healthy People 2010 and 2020, and the health issues of LGBT people, it was Institute of Medicine. There's a lot more resources out there, but I would say if you're looking to focus on some of the health issues in the community, there's some great places to start. So for those of you who don't know about transgender or don't know some of the basic terms, I'm going to go over it really quickly, and I hope you love this animation because that's about as fancy as I get. So when we think about transgender, we think about sex, the sex assigned at birth. That's the language I like to use because when a baby is born, a medical provider assigns them a certain gender, right, a certain sex based on genitalia. And so that's basically what it is. So I use the term sex assigned at birth often because that may not identify how someone identifies their gender now. So gender expression is how you express your gender. So all of you in this room, you got up this morning and you decided how you were going to get dressed and if you were going to put up makeup or not, how you walk down the street. That's all about how you express your gender. So when I used to work at Callan-Lord Community Health Center, we had some trans patients who would come in full suits and they'd change in the bathroom to a dress because in that appointment with their medical provider that they trusted and felt comfortable with, that's the first time they could express their gender as who they are, right? So you might see that as patients get more comfortable with you, they feel like, okay, I can be myself around you. And then gender identity is the internal self-conception of your gender, meaning how you feel on the inside. So I have no idea what anyone's gender identity is, right? We'd have to ask more questions to really know that. And all of this information is really important for how you treat your patients too. And there's a lot of changes coming down the road. Like NYU Langone is changing a lot of the electronic medical record to ask questions about sexual orientation, gender identity, sex assigned at birth, organ inventory, which sounds so odd, right? But it's really about when we send out emails for our patients coming in for gender confirming or gender affirming surgery, we have sex assigned at birth, we have gender identity, and we have organ inventory because we don't make it about a gender. We say, what organs do you have, right? Because that's what's most important. And that's not necessarily gendered. We know people of different genders can have different organs, right? Just sound a little strange, but. So we all have a gender identity, and for a lot of us, it matches how we were born, and for some of us, it doesn't. And that's a great way of understanding who transgender people are. So these are my really exciting stick figures here. Oh, I can use the pointer. It's not important at all, but I just really like it. So thinking about gender identity, in a medical construct, we think identity begins here, right? That's supposed to be pointing at genitalia, if you couldn't tell. And that's the way we think about it, right? If you're born with a vagina, you're a woman. If you're born with a penis, you're a man. But in actuality, you want to think for all your patients and all your colleagues that identity really begins in your head. So how you think about gender. Why that's challenging is because in a medical construct, we put people in these boxes, right? And we make things about women's health and about men's health. And that becomes really difficult for transgender populations. So just because we put this LGBT together, some people don't necessarily know the difference between the sexual orientation part and the gender identity, but sexual orientation is who you're attracted to, right? And gender identity is the gender that you feel on the inside. The best way to think about this is if you tell me that you're a woman, do I have any idea who you're attracted to? No, right? So you'd have to tell me more information. You're a heterosexual woman, you're a lesbian woman, or a bisexual woman. So those things are separate, your sexual orientation and your gender identity. But sometimes we put it all together and it gets a little confusing for people. If you get 10 transgender people in a room, you're going to get 10 different definitions. So it's good to be very broad, right? So I think of transgender as people who feel that the binary gender that they were assigned at birth, that male or female box that you're put into, is a misleading or incomplete description of yourself. So it really doesn't fit. And this can happen at any age. So for all of you working across the continuum of care, maybe you're working with younger people or older people, people can come out at any age. And I have a story about it that relates to NYU School of Nursing. So when I was here at school, we were doing a rotation at a nursing home, and I said, hey, we should ask the patients we're working with about their sexual orientation and gender identity. And everyone said, there's no way I'm asking these 80 and 90-year-olds about their sexual orientation, their gender identity. And I said, I'm gonna do it, because I was that person in school. And so I went up to this person, 80-year-old, male appearing person, and I said, my name is Nathan, I'm a nursing student, I'm gonna be working with you. I just have a few questions to get to know you better. How would you describe your gender? And the person started hysterical crying. And everyone thought, what did Nathan do to this person, right? Because that's who I was in nursing school. And the patient said, no one has ever asked me that question before, and I've always felt more like a woman. And here I am, 80 years old in a nursing home, and no one's ever asked me that before. So it really shows you, sometimes we think, oh, we don't need to ask people that we don't think are transgender. But we don't have T's on our foreheads, right? You can't tell by looking at us. You can't tell by our bodies all the time. You really have to ask those questions, and it can make people feel much more comfortable. So just to go back a little bit, transgender woman is someone who is assigned male at birth, identifies as a woman, and a transgender man is someone who is assigned female at birth and identifies as a man. There's also other terms like gender queer, gender nonconforming, gender non-binary, and the non-binary community tends to face a lot more discrimination within healthcare. Because as you can imagine, we put people in these two boxes, right? So when they exist outside of those boxes or use different pronouns, it becomes really difficult for healthcare providers or electronic medical records that don't create systems for this population. So speaking of pronouns, yell out some pronouns. What are some pronouns you know?
She, she.
Great.
Her.
This is just an opportunity for me to drink water. So she, he, we know. Other pronouns, I heard people say they. Some folks have a really hard time with that grammatically, but in the English language, as well as other languages, we are very gendered. And so sometimes if you don't know someone's pronoun or you've asked them their pronoun and they want to use they, that's another way of identifying someone. There's also gender-neutral pronouns such as ze and here. So this is just to note that when you ask your patients what pronouns they use, they might use different pronouns than we're familiar with, like she or he, right? So that's a really important question when you're working with any patient. So I ask all of my patients what pronouns they prefer. And the way that I do it is I actually introduce myself first. I say, my name's Nathan, I'm a nurse practitioner working with you today. I use he, him pronouns. What pronouns would you like me to use for you? And it makes it a little bit more comfortable. I mean, certainly there's some patients who say, why are you asking me that question? And I say, we ask all our patients so that we can respectfully identify our patients, right? So you all can practice that at home. So transgender health, we talked about pronouns. We're going to talk a little bit about what is the information out there, the data that's out there. 48% of transgender adults are delaying or avoiding medical care, and 29% of lesbian, gay, and bisexual adults, and 17% of heterosexual adults. So what do you imagine is going to happen when 48% of transgender adults are avoiding medical care? You can yell it out. Health problems, yes, and chronic health problems, right? You're not coming in for health care. This is going to be a very large issue. And this is another study that showed TGNC is transgender and gender nonconforming. And if you'll see here, 65.2% of transgender and gender nonconforming patients are experiencing healthcare providers that are unaware of their health needs. And why is this? We don't have it in our school, right? We don't always have it in nursing school, in medical school, in social work school. So then you have providers come out of school well-intentioned but have no idea how to take care of patients. So imagine you're going in to see your medical provider and your medical provider just says to you, I have no idea how to take care of you. I mean, that might be true, they just don't say it, right? But for a lot of transgender patients, they're getting that kind of reaction. I don't know how to take care of your health needs. And how that can make patients feel can be really difficult, right? We know as medical providers, as nurses, we're taking care of the whole patient. So think about what it looks like for a transgender patient to come into your office. So if you're doing rotations right now, if you're working right now, what does it look like when patients come in? Do they have to show their identity document, like a license or something like that? What is it like for a transgender patient who maybe can't change their gender on their ID? So each state decides how to change your gender on your ID. Sometimes, some states will say you need a letter from your therapist, some states need a letter from your primary care provider, and some states need a letter from your surgeon. You can imagine the ones that need a letter from your surgeon are a little bit more difficult, right? Not everybody wants surgery, not everyone can afford it, and that means that they might come in with a gender marker on their ID that doesn't match the way they look. And that might be first barrier before they even get to you. So you're the best nurse ever, super amazing about trans care, but they never make it to you because they're scared of that front desk and when they have to show their ID. People are rejected by their families, experiencing homelessness, refuse medical care, and suicide, unfortunately, is also really high in this population. You can imagine the kind of mental health issues that are existing. So some of the barriers, you can imagine so many, right? Being denied healthcare coverage issues. So what is it like for someone like me as a transgender man who's male on his health insurance information if I need to go in for, let's say, a GYN appointment? First of all, am I excited about that GYN appointment? I mean, is anyone excited about GYN appointments? Maybe not, right? Some people are really excited about GYN appointments. But for me to wait in that waiting room, right? And what is it like for me to fill out the form, the information, for me to finally make it back to the nurse, for me to make it back to the provider, and then for me to get my healthcare coverage denied because I'm male on my health insurance. So why am I there for, let's say, a vaginal pap? So those are things you want to think about, or like a transgender woman who's coming in for prostate screening. All of those things that are very gendered can be things that get kicked back, and the patients might say to you, I'm not going to come in for care if my insurance isn't going to cover this, right? And Sadly, we often have to manage people's insurance, right? It's not a part of, everything's a part of a nurse's job description, right? We think, oh, we don't do that, but we all do it. So those are things we have to think about. Sex segregated services, so things that are gendered, like women's shelters, men's shelters, women's like rape crisis shelters, anything that's a shelter, homeless shelters that are gendered are going to be really difficult places. Inappropriate name or pronoun use. Invasive questions about genitalia or transgender status. So I get this all the time, right? When someone finds out that I'm transgender, they ask me incredibly invasive questions. I have a story for everything, but I was doing a presentation for a group of doctors, and I was talking about inappropriate questions. And at the end, I came out, and the doctor in the back raised his hand. He said, "So I have an important question. What's in your pants?" I said, way to model inappropriate questions. You just thank you so much for that. But that's something just in a presentation. You can imagine there's another story of a transgender woman, colleague of mine, who went to the emergency room and had gotten in a car accident and broke her arm. And there were 9 doctors around her bed asking her if she had a penis or a vagina. I've yet to see the connection between the broken arm and the genitalia, but if you have one, let me know. So that really shows where there's a lot of invasive questions. There's a lot of inappropriate behavior that providers are just very curious, and they'll ask patients inappropriate questions. Access to hormones and surgery, which I'll talk about. Patients' trans status overshadowing other significant medical needs, right? So it becomes all about you being trans and less about, I'm coming in for a cough, let's say, and I've literally been asked questions about my transgender status, and I think, there's no such thing as a transgender cough, right? So it's just a cough. These questions are inappropriate. So this happens often. This is a great film, if you've ever heard of it, Southern Comfort, which you can get on Netflix. You have lots of time to watch movies, I'm sure, about a transgender man, Robert Eads, whose care for ovarian cancer was delayed because more than 24 doctors refused to see him. So think about what that's like, and I worked in oncology for 5 years, and parts of oncology are so very gendered, right? So think about women's cancers and men's cancers and how transgender populations will navigate that can be really difficult. So these are all health issues in the community: smoking, alcohol, substance use, anxiety, depression, sexually transmitted diseases, increased cancer risk. So it's not because someone is transgender they're getting cancer, right? It's because they're not coming in for the screenings that are very gendered, that can lead to not screening for something can lead to that, right? Mental health issues, so make sure that this is another thing for nurses to know about, when you're referring your patients out places to mental health, to specialists, that you make sure that they're trans-sensitive places, right? So mental health in particular has been a really difficult place for the transgender community since they've been pathologized for so long. So making sure that you have really helpful referrals is really important. And then we're going to real quickly talk about transition. But if a patient said to you, walked into your exam room and said, a transgender patient, I'm interested in transitioning, what would that mean to you?
They want to move to a new home.
Right? That could be something. Absolutely. Right? It's a word that can mean a lot of things. Anything else?
It could be transitioning in terms of presentation,
Mm-hmm.
even just clothing and how you're identifying yourself, but also, as it says up there, hormones or surgical.
Right, exactly. So, right, the answers are out there. But if you're thinking about, the reason I say it is because when a patient says to you they're interested in transitioning, my favorite question to ask, it's such a therapy question, is what does transition mean to you? Because I have been through the healthcare system and I say, I'm interested in transitioning. They say, great, we're going to start you on hormones, and I have a name of a surgeon. I thought, I just wanted you to call me Nathan and and that's it, and now I feel like I got to get out of this office. So sometimes that's all people want, right? They just want to be called a different name, to be called a different pronoun, and sometimes they might be interested in hormones and surgery. So it really depends on the patient. That's why it's so important that you ask that next question. So when you think about transition and a transgender man is coming in, he would start testosterone. And when you're thinking about all these different hormones, it's also nice to know what are some resources that you have at your fingertips, because a lot of this information walks you through it stage by stage. How to prescribe things if you're prescribing, what to look for, what are some of the changes that can happen with hormones. And so it's not as difficult as it might seem. A lot of people get very scared about hormones and taking care of patients on hormones, but a lot of the information is out there. So here's some great resources, and I particularly would focus on UCSF Center of Excellence for Transgender Health. They will literally tell you step by step, this is what you want to look at. This is what labs look like. This is what medication you're on. So when you're a nurse saying to a patient, what medications are you taking or what surgeries have you had. You want to know what all the medications and all the surgeries are. And so these are some great resources. So WPATH is World Professional Association of Transgender Health. And these are the things I go through when I'm prescribing hormones. I go through the goals. Goals are really important, right? What are the goals of transition? So I've had a patient say to me, I'm going to start testosterone, and the next week I'm going to have full beard, I'm going to have a booming voice, and all my friends and family are going to accept me. So good thing I asked about goals, right? So we can walk through and say those expectations might not meet exactly what's going to happen. So you want to talk to your patient about that. Reproductive options, which I'm going to talk about, their expectations, and really how to monitor and document it. And informed consent just basically means that trans people know what's best for them, right? That's the most important thing to know. And you'll see a lot of trans patients who are very educated on their own health. So if you're working with a transgender male who's on testosterone, they most likely will be on injected testosterone. It's just because it's the cheapest. So there's intramuscular injections, and there's also now subcutaneous injections. So you want to be aware, you know from nursing education what IM injections and sub-Q injections are, but you want to have more of an idea of how people are using testosterone. There's also transdermal, which is sort of like a gel that you can put on. It does rub off, so you have to ask people to let it dry first, because sometimes people will have partners that maybe don't want chest hair. So that's important to talk about. And then pellet implants, which is implants that will last about 6 months. And this is really what you want to think about. We don't necessarily keep testosterone from people unless these particular reasons. So there might be basically hormone-dependent cancers. That's something you want to think about. Active pregnancy. Those are all things that you'd want to kind of have a red flag if that patient wants to start testosterone and they have these issues going on. And I know my work as an RN, I felt like I was often catching the mistakes of medical providers, right? And that's why I think it's so important for us as RNs and NPs to know more about these issues, even if you're not prescribing, because you might catch something that the medical provider didn't. And so that's why it's important to know these things, right? That you'd want to manage that with an oncologist. This is kind of a busy slide, but it's a really great slide about what are the changes with testosterone. And you want to know this as a provider to think, oh, okay, my patient started testosterone. That's what's happening with these particular effects, right? So facial body hair growth. It also tells you when it's going to happen. So 1 month to 6 months, and so they'll have more of an expectation when things are going to change. Body fat moves around, deepening voice. The menstrual cycle will stop depending on how long someone's on testosterone and what dose. So what's something you might think about if you know that's going to happen from testosterone for a patient of yours?
What are the thoughts of becoming a parent one day, right?
Exactly. So both, what if someone's interested in getting pregnant, and also what if someone's not interested in getting pregnant, right? Both of those things are really important, because the sign that we often know that you're pregnant, you're late on your period, right, for some people. And so if you're not getting that because of testosterone, then it's really important to have that conversation about safe sex or birth control, or a conversation about if they're interested in getting pregnant, which I'll talk about in a little bit, in which case you'd want to go off of testosterone. The other thing that can happen is if someone is not doing their shot regularly, it's every week, every 2 weeks, they can get spotting. And so often we think about vaginal spotting. People have come in the emergency room for vaginal spotting, and not everyone's thinking, I should ask them about their hormone use. So that's something just to think about, differential diagnosis, which I'm sure you have in some of your classes. And then there can be effects of blood pressure with testosterone. So that's something you just want to be aware of. If someone had really high blood pressure, I wouldn't necessarily not prescribe testosterone. I just want to manage their blood pressure, right, at the same time as I'm managing their testosterone, talk about diet and exercise. So transgender men, have people heard the term cisgender? So cisgender refers to people who are not transgender, basically. So transgender men who are having sex with cisgender men, right, and they're unprotected sex, they can get pregnant. So that's what we're referring to before. But they shouldn't be on testosterone. So if you know someone's having unprotected sex and fits into this category that you could have a baby, right, and they're able to, they haven't had a hysterectomy or anything like that, you want to be talking to them and they're not interested in getting pregnant. You want to talk to them about birth control. But birth control resources, right? So the last place I was at that I worked at, their birth control resources were so heavily focused on women is everywhere, right? Women's resources, women's birth control. And understandably, that's really important to a lot of communities. But for transgender men, they were never picking up that information because that's not how they identified. So they weren't getting the information about birth control that was very important. So I find that you have to kind of change the language around things and make it more about what's going on with your body and less about gender, right? So people seen this picture before? Oprah was all about Thomas Beatty. So that's Thomas Beatty, who's had 3 babies, but before he had his babies, 9 OBGYN providers refused to see him. And his actual care of delivering is exactly the same as a cisgender woman, but because of the way his body looks and because of the way he looks, OBGYN providers were refusing to see him. And this is very, very common, right? So my partner is a transgender man who delivered our amazing baby who's 1 year old. And that's why I don't have a lot of sleep. But so, and this is just a year ago, right? And he had so much difficulty finding an OBGYN provider who was sensitive and aware of what are some of the needs, right? Going off of testosterone. But beyond that, the delivery is the same. But what is it like on, let's say, an OBGYN floor? What is it like postpartum floor? What is it like for floors where you're always seeing women and you're always saying mother, right? So really being able to change some of that language. If those are floors that you're working on or you will be working on, changing things. So I say pregnant people, right? I say parent, which I think is important anyway, instead of saying just mother. So that's really important work to be thinking about. And some of the monitoring, when you're thinking about what labs are you looking at, so you want to be looking at testosterone, liver function, that can increase red blood cells. So some of the stuff that you just want to glance at patients' populations for transgender men, cholesterol, A1C, that's the sort of things you want to be managing. And I always want to think, how are my patients doing after transition, right? Not always do medical providers ask them, you've been on testosterone for this long, how are you feeling, right? How has your mood been? How is your sexual activity? All of that is really important. And then my favorite quote, well, I have a lot of favorite quotes, but if you have it, check it. So it's not about you're a woman, do this, you're a man, you do this. If you have this body part, that's what you need to check out, right? And because I worked on oncology for so long, we use this language anyway. Because we had, let's say, a cisgender woman who no longer had breasts because of cancer, or a cisgender man who no longer had testicles because of cancer. We didn't say they were not a man or not a woman, right? We just said, if you have this body part, this is how you take care of it. So really degendering some body parts is incredibly important. And I now work in the surgery field, which is so completely different than any other field I've been in before. But it's really, really interesting to work with patients coming in to really align their bodies with how they feel on the inside. So a good term to use is gender confirming or gender affirming surgery. So when you want to ask a patient that, instead of saying gender reassignment. So this is just a language thing to be familiar with. For your transgender men, especially folks who are doing working in any hospital floor post-surgery, you want to know what are these surgeries and what are some things to look out for. Hysterectomies, we know what that is, right? Chest reconstruction can be, there's a lot of different kinds of chest reconstruction, but the care for it is very similar to mastectomies, right? So you'll have JP drains, you'll be teaching patients how to take care of their drains, and it's just that you have a male-appearing chest afterwards as opposed to reconstructing your chest. There's also metoidioplasty, testicular implants, and phalloplasties, which are not as common, but they're bottom surgery. So metoidioplasty is enlarging the clitoris, and a phalloplasty is taking skin from the arm or from the leg, a graft, and creating a phallus or penis. There's a lot of complications from this surgery. This surgery is about 8 different surgeries and happens over the course of 2 years, depending on if you want urethral lengthening, depending on if you want an erectile device put in. I know so much about surgery that I didn't know about before, but I think the most important thing with these surgeries is you know what to look for, right? You're not necessarily a surgeon, but you want to be in contact with the surgeon. You want to know, are you looking for wound, how do you take care of wounds afterwards? How do you take care of any urinary issues afterwards? Most important, are they connected to their surgeon, and is that communication working well, right? That's incredibly important. And at NYU Langone Health, where I'm at now, we have a really amazing surgeon, Dr. Bluban Langner, who does all of these surgeries. And we really do a great job of taking care of the patients before and after and making sure they understand how to take care of these body parts, because when we send them out afterwards to their primary care provider, if they need to go into the hospital, a lot of these providers have no idea how to take care of these surgeries because they never learned about it, right? So that can be really frightening. So for transgender women, they would go on estrogen, and some of the things you want to think about with that, if they have history of DVTs, because estrogen can increase that, if there's any issues about liver disease, if they're on what's anti-androgen, there's spironolactone, which you might have heard a lot about just in how you take care of blood pressure. So you want to look at their potassium. These are some things you just want to think about before you're prescribing or you look at your patient's medical list. And the changes from estrogen kind of are the reverse of the changes from testosterone, right? So body redistribution, the skin will soften, there's decreased muscle mass, and then another thing related to fertility is there's decreased erections and decreased sperm. So if I have a patient that's starting estrogen and no one's talked to them about whether they want to have children with their own sperm, that's something I would want to address right away, right? And I'd want to say, do you want a referral for sperm banking? Because that's something that they might not be thinking about, but they're about to take something that can decrease that. So things you want to really think about. And I'm just going to kind of like do a little bit of skipping. So we talked about sperm banking and then the medication list. So you're asking your patient, what medications are you on? And let's say you see spironolactone. We always think blood pressure, but maybe if there's not a blood pressure issue, it might be. And there's different dosages for blood pressure versus a transgender patient's on it for their hormone care. It might be for an anti-androgen or testosterone blocker. So you want to be very aware that estrogens can be transdermal, can be oral, can be injectable. So those are the things you're going to look at when you look at that medication list. And you want to make sure they know how to take care of their own, how they know how to do injections. They know they're getting their labs checked. That's another thing. A lot of patients will tell you what hormones they're on and they haven't come in to get their hormones checked in years. And it might be because they don't know anyone that they feel comfortable with getting that checked. So that's incredibly important. Silicone is also an issue in the transgender women's population, so people injecting silicone in order to have more curves, more breasts, more hips, and we know that that can be really dangerous. We just had a case at NYU in the emergency room for someone who came in whose silicone had moved and had a huge mass in their leg, right? And no one understood where it had come from. It's because she was injecting silicone with her friends and not medically at a healthcare institution. So that's something that you want to think about also for a differential diagnosis. And quickly about surgeries for transgender women. So breast augmentation, orchiectomy, which is the removal of the testicles, and then a vaginoplasty, which is a very, very common surgery for trans men, which is basically creating a vagina out of a penis. And it's also a very successful surgery. A lot of GYN providers I work with say that they had no idea this person had a vaginoplasty, right? So there's things you have to do after a vaginoplasty, like dilating to keep the vaginal canal open. There can be urinary issues down the road. So those are all surgeries that you want to really know about. Tracheal shave is shaving down the Adam's apple. I pointed here like I have an Adam's apple. I don't have one, but that's the area and facial feminization. A lot of these are covered under insurance now, which is a huge change than what used to be. People had to sort of pay out of pocket for this, but there's a lot of hoops you have to go through to get things covered, right? You need letters from your mental health providers, from your primary care providers, so it's difficult to get it all covered. And I'll also say if trans people can safely change their bodies to become who they truly are, they will protect their bodies because people who are happy in their bodies take better care of them. And I feel like this is all on us, right? To help transgender people feel more comfortable in their bodies. When I was doing primary care as a director of transgender health, I don't have research on it, I just have my own stories, that when transgender patients were called the right name, the right pronoun, were respected for their bodies and their identities, I noticed that their asthma got better. Right, that their A1C, they were taking care of their asthma, they were taking their diabetes medication, their A1C was going down because they actually saw their bodies as something that should be respected because they were being treated well. So that's something little that we can, I mean, it's huge, right, that we can all do as nurses to take care of and respect a patient and see how it affects their health and their chronic health issues. So I'm sure I'm over time, so I'm going to do a little bit of real fast skipping, but sexual health, how many people feel comfortable taking sexual health on a patient? No one ever does. One person. So sexual health, I want to just quickly say, if I come in for a HIV test and people ask me, do I have sex with men, women, or both? Do we feel like that is a super inclusive question for transgender populations? It's sort of a setup question, right? But I've gone out to HIV testers and I'll say, oh, I'm having sex with men. And they'll give me all information as if I'm a cisgender man having sex with another cisgender man, right? And we both have penises and this is how we're having sex. And usually halfway in between I say, hey, surprise, I'm actually a trans man, my partner's a trans man, and all the information you gave me doesn't relate to my body, right? They love when they do that. So it's really important that you ask people, I actually ask people what body parts are touching what body parts. It sounds like a weird question, but that's what you want to know. If someone says they're having sex with a man, you don't know what kind of sex they're having, right? So you need to know what kind of sex they're having, what body parts are touching what language people use. I ask every patient, what language do you use to describe your body parts? Because some trans women may have a penis and they may call that their vagina. Or a trans man has, let's say, breasts and he calls it his chest. So all of those things you can change a patient's experience by just asking them, what language do you use to describe your body? And then you have to use that language. And I have to say, it's actually cisgender people who have the most interesting names for their body parts. Like, really, like, okay, call my hoo-ha, and then Mr. This or Miss This. So there's really a lot of different names that are out there. So HIV is also high in this population. We talked about decreased cancer screening, right? So really just being sensitive. Talk about body parts. If you have it, check it. Think about all the things you need to know. That's why that organ inventory is important. What body parts do you have? What do you call them? How do you ask sensitive questions? I ask all my patients about what pronouns they use. Look at your electronic medical records wherever you're working and think, is this inclusive for transgender populations? Not that it's super easy to change electronic medical records, but there's a lot of changes that are happening right now. So be able to know what are the challenges in the places that you work in, right? And just use the language that people are using for their bodies. Ask people why you need information. As a transgender patient, I always want to know, why are you asking me that? Is it because you're curious, or is it related to something? So if I want to know about the hormone use, I'm going to ask you about hormone use as it relates to maybe your risk for cancer or whatever it might be. And then they know this is actually related to something, right? You need this information for a reason. Bathrooms. So bathrooms are huge. These are my favorite bathroom signs, especially the "Let my people pee." That's one of my favorite ones. But if you have bathrooms in the place in which you work, they might be super gendered. There might be the women's bathroom, the men's bathroom. And I've had patients come in, look at the bathrooms, and leave the clinic if they don't see a gender neutral bathroom option. Because that can be a really tough place for a transgender person to come in, and another patient might say, you're in the wrong bathroom, right? So that's really, really important. Important questions to ask we really talked about, but have you had any gender confirming surgeries? Tell me about your transition. These are all great open-ended questions to ask your patients. And we've talked, you can tell I like to have way more slides than I have time for, but there's so much information, right? Rainbows go a long way. So if you put a rainbow sticker on your name tag, that can really show that you're an LGBT inclusive and sensitive person to talk to. And everyone knows if you talk about JACO or the Joint Commission, especially in the hospital, people will go running. They hide all their water and their food and they freak out. So know that this is a resource if you're working in a hospital that I used to my advantage when there were people who were not so LGBT sensitive. I would say, hey, JACO put out a guide, right? So therefore you need to focus on that. Sometimes that will work, right? Threatening people sometimes works for being more inclusive. And then there's some great resources out there. The Center of Excellence for Trans Care I talked about. GLMA is the Gay and Lesbian Medical Association. Silver Bear Law Project. Great resources out there, and I'm happy to give you all more resources as you start working with more transgender patients. This was actually the registration form on Cal and Lord, and it shows you there's legal first name, legal last name, and then chosen name if different. You have choices for gender identity. It explains why you need certain information, like the sex listed on your insurance information, right? So all of that can make a patient feel so much more comfortable in your healthcare setting. We're never going to talk about this, but if you go back to your classes, think about what are the lectures, the classroom activities, the rotations where you can integrate this in, right? Because as a student in this program, I felt like I really was able to, especially in that independent study, have suggestions for, we can include LGBT care in here, or we can make this case study a transgender person who has asthma or whatever it might be, and that helps push a lot of this, because it's really the students a lot of the time that help push some of this curriculum. So hopefully you all will be doing that, and there's some great resources online, the Fenway modules, Trans Bodies, Trans Selves, and we did it. We got to the end, and I talked very fast, but I want to leave a few minutes for any questions you might have, and drink some water.
Nathan, in the NP program, we talk about, and especially when you're in a place where you're providing primary care and clinic rooms and that sort of thing, there are certain policies about chaperone use and it's usually gender binary sorts of issues. So what sorts of things influence, if they do, chaperone use in the trans community?
Yeah, so everything is sadly so gendered. Right, but being able to work with chaperones and being able to work in a system by saying this is a transgender person, providing some education in that field, and also being able to change the language around it. So a lot of people say they want someone to be male or they want someone to be female, but being able to really talk about what patients feel most comfortable with. I find that it's actually, for a lot of trans patients, if they have someone who's trans sensitive and aware, it becomes less about the gender and more about, can you help me navigate through this system? I think chaperones and healthcare navigators, people that work in that field, are so helpful for this community, because often it's just like, how do I make this appointment? How do I show up at the front desk? Who can help me going to the emergency room? All of that, it requires a lot of education for people that are going to kind of escort and navigate patients, but often it's just about who knows what trans care is, who's going to call me the right name and the right pronoun, and that's so important. Any other questions? I only went over just a little bit of material, you know.
So what's your patient population like at Langone? Do you have an excess number? Do you have a waiting list, that sort of thing? Or how is it going over in the community?
So we were just talking about this today, that we have at least 60 patients a day, but not for one person, shared among 3 people, but it's about a good 20 to 30 patients a provider that the surgeon will come in and take a look at. So it's pre-op and post-op care. So there's a lot of post-op, and the surgeon I work with wants to have follow-up very often, really close follow-up, because it's hard to send patients out into the world and feel like they're going to be well taken care of. So the patient population is very diverse now that insurance is covering. So now Medicaid is covering trans surgeries, which is huge. Not all surgeries. Facial feminization is one that's very hard to cover. But because Medicaid is covering it and other insurances, we see a huge influx of people that are of all different economic backgrounds. It used to be only people that had money to come in for surgery. So now we're seeing all different backgrounds, people that are coming in that we really have to talk about. Shelters, right? They might be coming in homeless shelters, and we say you can't recover from a vaginoplasty in a shelter, right? So we see a lot of patients. The surgeries are booked into 2019 already. So this is a huge need in the population for surgeries, and it's growing, and people are coming from all over. So we see patients, majority from New York, but people are also coming from California, from DC, from all different areas, because they want to find the surgeon that they feel has the best results, that is the most sensitive to the community, and that will help them feel like they're really taking care of their bodies, right? Because it used to be people would go all over. I mean, as Dean Pace was saying, people would go to other countries that might not have had as quality care or as quality follow-up because it was cheaper, right? And they'd come back with all sorts of post-surgical complications, end up in emergency rooms that had no idea how to take care of them. So being able to find that quality surgeon is so important, but I had no idea how many patients we would be seeing. It is unbelievable, and it's interesting to come from primary care into this, where I can still sort of manage and see you're not actually connected to a primary care provider. You're interested in surgery, but you also have diabetes and all these other issues, and HIV that's not managed because you're focusing only on your surgery. Right? So it's interesting to come in with that lens and say, let's connect to all these other parts of your care.
Have you noticed a shift in the age range?
Yeah, so we have people coming in, well, both on the younger end and on the older end. So I saw a patient that was 12 who came in with his parents for chest surgery. And then I also saw a patient who was 79 who had had a vaginoplasty in the 70s. And was coming in for a revision. So we also have people coming in to sort of fix the work of other people that maybe weren't as skilled or knew what they were doing. So across the board, very different ages, and it's very interesting to see people coming to their identity either super early or much later in life, navigating this surgery field, right? And being able to feel more comfortable with their bodies and relearn their bodies. So it's really interesting to be teaching transgender women, this is where your clitoris is and your labia, right? That's not body that they grew up with. So being able to really teach them their bodies and how to use it and how to have sex safely and how to know when something is wrong is so important. Sometimes the extremes of ages have more trouble with really understanding that, but we're seeing across the board different ages. I think people are also coming out younger and younger as transgender. And speaking of younger and younger, I always say, what's the first question that people say when a baby is born? Boy or girl, right? And so when my brother had a baby, he said, it's a girl. He called. I said, oh, for now. And he didn't really love that answer so much. But as myself as having a baby, we worked with the hospital floor to say, please don't have a gender announcement. We would like to know our baby is healthy and okay, but we don't need a gender announcement. And people had such a hard time with that. So before birth, when people said, is it a boy or girl, you could kind of get away with saying, it's going to be a surprise, right? So now I still say it, and my child is 1 year old, and so they'll say, oh, boy or girl, I said, oh, it's going to be a surprise. I said, what are you, we don't know yet. Our child hasn't told us. So it's very interesting to see how invested people are in the very young babies, about what is their genitalia and associating that to gender. So it's been real interesting, and I'm sure I have a lot of interesting gender things ahead of me, right? That apparently sparked some questions.
I'm curious, with adolescents to adults, what is the age when one can actually take control of their body and do what they want to with it?
For surgery, you mean?
Well, whatever.
Oh.
Hormones, anything.
Sure. So depending on the place, for hormones and for surgery, if you're under the age of consent, you need parental consent, which is tough because a lot of transgender people don't have parents that are very sensitive.
Is that 18?
Yes, and so some of the providers, like the places I've worked in the past, don't necessarily do hormones for those under 18, but there are places out there that do, and you do need the parental consent, or if they're in foster care, you need a foster care worker to consent for them. For surgery, again, it's parental consent, but it's also the surgeon the surgeon I work with usually works with an adolescent therapist to really get a sense of if they have the capacity, because that's the most important thing, if they have the capacity to make these decisions. For chest surgery, it's very different than for genital surgery, because for genital surgery, you're kind of making decisions around sterilizing your body for some people, and they usually need a little bit more of connection to a therapist or a psychiatrist to have that conversation about their readiness for surgery. But for hormones, people are younger and younger saying that they often will go on puberty blockers if their parents consent before the age of puberty, because as we know, puberty was never fun for anyone, but definitely for a transgender person, that can be incredibly difficult. So puberty blockers is a bigger thing as well now too. But the challenges are having parents that are accepting of them.
Yeah, that was similar to what I was thinking, because I have a close family friend who has now a third grader who is trans male. So like I'm always kind of thinking just that. I've heard talk about puberty blockers, but then you said 12. That someone was bringing in their child, so they've developed their secondary sex characteristics, and they're making a decision now to remove the breast tissue. Is that what you're saying?
Right, and there's some interesting dialogue about that, because sometimes it's better for surgery outcomes to have developed secondary sex characteristics depending on the surgery. So it's something each surgeon's going to decide for themselves, but it's amazing also to see patients after surgery, especially younger patients who just finally feel comfortable in their bodies, and to see the way in which they're just crying with joy to say, I finally feel like I can look in the mirror again, right? But they're hard decisions, because you want to make sure your patients can consent and understand the long-term effects of what they're doing. Everybody wants to eat and drink now, right?
Hey, could I just... Shannon is in the room from VNS-NY, and I just wanted to say that I'm so happy that VNS-NY has a gender-affirming component to their care now. Were you able to...
I did, and I can't wait to talk to you about it after. It's so important, and we also want to send a lot of our patients who go home after surgery to have someone to help take care of them. They might not have support at home. They might have a lot of these genital surgeries are very complicated, and they need a lot of help at home. And so we always get nervous if we're sending someone into the home. Will they know enough about this surgical procedure? Will they call them the right names or pronouns? So it's really great to hear that resource is there.
We're just really happy to be doing this. March is going to be finishing up our second year. We've convalesced about 120 patients who've undergone gender-affirming surgery. And I've taught about 150 clinicians throughout the 5 boroughs, various zip codes, to care for these patients. It gives them a safe space to convalesce. And these are clinicians that actually volunteer and want to take care of these patients. And then once we do the big training, they have a big training on culture sensitivity, and then on aftercare, I'm getting called all the time, when am I going to get a patient, when am I going to get a patient? Can I have another one? Because they just love developing this skill set. So I'm just so happy to see all these nurses in here today and the work that you're doing. It's so exciting for these patients to finally have a place where they feel comfortable, and a knowledgeable clinician coming in instead of them having to teach the clinician.
Right, exactly, especially coming into your home, right,
Yes.
and taking care of you. And I do trainings for the NYU Langone floors that our surgical patients go to, because a lot of the nurses have no idea how to take care of a patient after a vaginoplasty or a phalloplasty. What do you do with the, Foleys and things like that we know about, but are you elevating things? How can you sit? What am I looking out for? When do I need to call the surgeon? So all of that is so important. And if you ever want more information about that, all my cards are up here, because this was way too much material for a short period of time. So there's so much out there, but there's also some great guides that are online and free that can help you learn more about it.
So I often hear from people who are transgendered how they've had really traumatic experiences within the medical field, and I just wanted to know if you had any advice or any suggestions for us, like being a provider who is trans-sensitive, and then helping patients navigate and reconcile their relationship with healthcare.
Sure, so that's a large question. So that's really important. I think recognizing that most trans people have had negative experiences in healthcare, and that's usually why they don't come back. Something that goes a long way for me and other people in the population is when you ask someone if they go by a different name, their chosen name. A lot of people say preferred, and although that is helpful, I actually like the term chosen better because I don't prefer that you call me Nathan. I would let you need to call me Nathan, right? So the pronoun that you go by can really go a long way. I know I feel so much more comfortable with a provider who starts that way, and also providers who admit what they don't know. I mean, I know we don't know so much, but or nurses that admit and say, I want to be able to refer you to a sensitive place. I can do some research to find a good place to refer you to. Do you need any assistance with going to? Sometimes I've escorted patients to the bathroom because I know the bathrooms are so gendered. I know we don't have a lot of time for those sorts of things, but being able to recognize the obstacle before the patient has to go through it is so important. And really putting yourself out there and saying, I want to be as sensitive as possible. Please correct me if I've done anything wrong. And I mean, you're going to make a mistake. It's really important to know that you apologize and that you put yourself out there as a sensitive provider to help navigate a field that is incredibly difficult and incredibly scary for patients. And I once had a provider just say to me, a nurse actually say to me, I know this experience can be so difficult, right? Because our system is very gendered. And that was it. I mean, I was like ready to cry already. Just it goes a long way when you can at least recognize that there's an issue because I already know it, right? I know this is difficult. And so putting it out there and not ignoring it can go a really long way. And then knowing your resources in the community. You're in New York City, if this is where you're working, there are some really wonderful resources. LGBT Health Center like Callan Lord. There's an LGBT center that's in Chelsea. So all of these things, you can get those sort of resources. And showing that you have resources can go a long way too.
We have time for one more question. Nathan, I have this big smile on my face because we are so proud of you. You represent NYU Myers in the best way possible. I've been moved to tears a couple of times just now listening to you, and the amount of information, the evidence that you bring to us makes me and everyone in this room who is from NYU Myers so proud of you. And thank you for the work that you do. And thank you for being here tonight and opening our month of celebration.
Thank you, everyone.